everyone, and thanks for joining us on this nice, cold, first wintry Monday afternoon. My name is Leslie Tarasov, and I'm a PhD candidate here at the School of Public Health, and I'll be facilitating today's event. I just want to start off by saying a few thank yous, and then Dr. Hu, the Dean of the School of Public Health, will say a few words before I introduce our speakers for today. So first, I want to thank Dr. Hu and the School of Public Health for supporting this lecture and discussion and the earlier student event. I also want to thank our partners and supporters, the University of Toronto Sexual and Gender Diversity Office, the Munk School of Global Affairs Comparative Program in Health and Society, the Public Health Students Association, and the Mark S. Bonham Center for Sexual Diversity Studies. I would also like to thank my fellow planning committee organizers, and I just want you to all give everyone a round of applause for organizing today. So now I'd like to introduce Dr. Howard Hu to say a few words.
Thank you, Leslie. I think the last events of the few weeks that have preceded this have underscored how important these kinds of events are, and also how glad we are to be able to host this event, the Making Trans Health Count, Inclusion of Trans and Non-Binary Participants in Public Health Research event. Both Professor Lori Ross and Leslie Tarasov deserve congratulations in organizing this event, along with an organizing committee. It embodies the core values of our school, particularly as it relates to equity and social responsibility. This is an educational event that's not just about you coming to this event, but all of the faculty, staff, and students who make up our community deserve to learn more about these issues. I'm very glad that we also have our Director of Communications here, Nicole Bodnar. This event will be filmed and will be made available publicly. I'll be looking forward to seeing some of those clips myself. Unfortunately, I won't be able to stay today, but I just wanted to make sure I could personally be here and tell you how glad we are to host you. We consider ourselves a leading school of public health for being able to stimulate discussion about how to reduce disparities and address systemic issues related to discrimination, whether it's based on biological sex, race, ethnicity, sexual orientation, cultural background, religious affiliation, age, physical or mental ability, and most pertinent to today's event, gender identity or expression. The impact that violence and discrimination based on gender identity or expression has on health is well documented. The Trans Pulse study, which I was delighted to learn about, and which we'll learn much more about today from Dr. Greta Bauer, has played a key role in documenting the impact of discrimination on the health of trans communities here in Ontario. For instance, in the recent paper that I became familiar with, Dr. Bauer reported that 35% of trans people had seriously considered and 11% had attempted suicide in the past year of the study. Dr. Bauer used data from the Trans Pulse study to show that interventions to increase social inclusion and reduce transphobia have the potential to substantially reduce these very high rates, and that's what population and public health is all about. It's one example, but just one, that illustrates how discrimination based on gender identity or expression negatively impacts health in direct and indirect ways, and also shows the potential for the response of our community to make a significant difference in the lives of trans people. I commend the event organizers for stimulating the enlightening discussion that will surround this event and about how we can work in partnership with the trans community to take action against the influence of inequity and improve the health of communities both here in Toronto and beyond. And we ourselves here in the School of Public Health will be working on creating the entire school is a safe place for conversations, some of them difficult, on how these things can happen. I strongly encourage everyone here to participate in today's discussion and think about ways you as public health professionals can work to address these and other inequities. Thank you, and enjoy the evening.
Thank you, Dr. Hu. So I'm honored to introduce our lecturer today, Dr. Greta Bauer. Dr. Bauer is an associate professor and graduate chair in the Department of Epidemiology and Biostatistics of the Schulich School of Medicine and Dentistry at Western University. Her research interests include LGBTQ health, community-based epidemiology, validity issues in observational studies, methodologic and ethical issues in studying hidden populations, public health ethics, and others, some of which she will speak with us about today. Dr. Bauer was a principal investigator on the Trans Pulse Project, a community-based project exploring the health and health care service experiences of over 400 trans people here in Ontario. Currently, she is PI of CIHR-funded research exploring the clinical care experiences and outcomes of trans youth, and a PI of another CIHR study focused on improving quantitative research methods in gender, sex, and population health. I am also delighted today to introduce my friend and colleague, Dr. Alex Abramovich, as our discussant today. Dr. Abramovich has been addressing the issue of LGBTQS youth homelessness for the past decade and is an internationally recognized leader in this area. Dr. Abramovich is currently an independent scientist at the Center for Addiction and Mental Health, where his program of research focuses on LGBTQS youth homelessness, access to mental health services, and the experiences of LGBTQS youth in shelters and housing programs, and the ways broader policy issues serve to create oppressive context for LGBTQS youth. He has worked closely with municipal and provincial governments to develop strategies that address the needs of queer and trans youth experiencing homelessness, and is committed to research that successfully and ethically engages the community and situates queer and trans youth peoples experiencing homelessness as knowledge makers and creators. Following Dr. Greta Bauer's lecture, Dr. Abramovich will provide a response, and then we'll open up the floor for questions. Our time here is limited to 6 o'clock because there's a class here in 6:10, so we're gonna have to be brief with the questions. However, following the lecture today in the 7th floor above us, we will be holding a reception, so if you have any more questions for the organizers or the speakers today, you can ask them then. And I also want to make note of some logistics issues. So you may have seen there is someone with two people with cameras in the room. So there's someone taking photographs and recording the event. However, only the speakers will be photographed and filmed, and the Q&A session will not be filmed. Also, to let you know that there are all gender washrooms in the building. There's one on the floor below us and one on the floor above us if you need to run out and use the washroom during the lecture. But hopefully you won't, because I think our speakers will provide a lot of interesting things to think about, so you'll be too interested to get up and go pee.
Really tiny on the screen here and try to find places to click. Hello, lovely humans. Welcome. So it's an absolute pleasure to be here today. I'd like to start out with a couple of acknowledgements. First, I'd like to acknowledge the Indigenous peoples on whose traditional lands we're meeting today. That's the Huron-Wendat people and the Seneca people, and most recently the Mississaugas of the Credit River. So it's with an immense amount of gratitude that I'm here tonight with all of you, meeting in this place that has been a traditional meeting place for a long, long time. So thank you. And I would also like to acknowledge that it's the time that we're in here. It's the day after Trans Day of Remembrance, the day when trans community and the people come together to remember those who've died due to transphobic violence. People who are largely trans women, largely in the global south, and who are largely put in situations of vulnerability through sex work and through economic situation. And so I just think it's a fabulous time for us to be focusing on equity and on what we can do to take care of each other and each other's health and well-being. And so this can be part of my small contribution toward that. Okay, and more acknowledgements. So no work is ever done by one person, and so I'm going to be presenting work off of a couple of projects. I'm going to really frame this, because I had a 5-hour lecture for you, but then I had to toss 90% of it out, right? So I'm really going to be framing this around what we can do through trans inclusion and public health research. I'm going to talk about that in 2 different ways. Trans inclusion in research that focuses on trans communities specifically, and trans inclusion in broad population data sets, such as the kind of things that Statistics Canada does, because they're really different in terms of what that would look like and what you can do with it. So I'm going to talk a bit about TransPulse from the community end, and that's a decade-long project that's involved all of these people, and I want to acknowledge them and to point out as well that over 70% of the individually named people that you see are trans themselves. So they're bringing to the project not just their own experience and knowledge of their communities, but also their experience as social workers, psychologists, doctors, and other professional experience that they have. And then I'm going to be talking about some work that's not yet published from a new project on incorporating intersectionality and multidimensionality into population health research. And specifically, I'm going to be talking about one objective from that project that's about how do we develop trans-inclusive measures of sex and gender for broad population surveys. So I'd like to acknowledge my co-authors on that, Dr. Bramo, almost Dr. Shine, and Chris Dharma, and all of the other people who provided feedback, but who bear no responsibility for anything I'm about to say. So if you disagree, those are my authors, and all the people at the bottom, they're innocent. So let's start with sex and gender. So this is just a table from a chapter I did for the Canadian Institutes of Health Research casebook on sex and gender. And it's not meant to be exhaustive. It was just meant as a tool to help researchers think what some different dimensions of sex and gender might be that might impact health and that we might thus be interested in for research. So if you look at sex, you'll see chromosomal sex, sex assigned at birth, hormonal sex or hormonal milieu, genital reproductive organs, secondary sex characteristics. So we sometimes say sex is biological and gender is social. As a researcher, when I'm thinking about health, I think of that broken down a little bit more, because these can all impact health in different ways, in the ways that they are combined or not combined with an individual's can. And then for gender, we have gender identity, what people know themselves to be, lived gender, the way they express that to the world, and conventional masculinity or femininity, which, while I say conventional, are culturally very specific and time specific. And then if we cross-classify, we can identify trans people under the broad umbrella as anybody for whom sex assigned at birth does not match up with gender identity. And then I put trans identity separate because, of course, you can be trans under that definition and not actually identify as trans. So some trans people will just identify as men or as women or as something other than trans. And so this is what I give to researchers kind of as a starting place to think about what's important in the type of research that they're doing. Because if you're interested in long-term cancer risks, you might need to know anatomy. If you're interested in the kind of things that, that impact experiences of discrimination, it's probably less about anatomy and more about lived gender and the way that people are presenting themselves to the world and being read by others, and the ways that they might be targeted as a result. So from this as well, just a little terminology for the day. So the title, I put non-binary in the title, but when I use trans today, I'm using it in an inclusive way to mean anybody whose identity doesn't match the sex assigned at birth. So if I say trans-masculine spectrum, I'm talking about people assigned female at birth who identify as men, or as agender, bigender, some other non-binary identity. And similarly, if I say trans-feminine people, I mean trans women and other people who were assigned male at birth and now identify as something other than male. And if I say cisgender, those are just the people for whom sex and gender identity and sex assigned at birth line up. So people who've taken organic chemistry always know the prefix cis, other people don't necessarily. So, okay, so what kind of information can be produced from community-based research studies? And here I'm drawing again on TransPulse. This was a decade long, as it was, we're still putting out the last few things. It was a decade-long, intensively community-based multi-mode project that studied the impact of social exclusion on trans people. So we started out in 2006 with 3 focus groups or community soundings, followed up in 2009 and 10 with a respondent-driven sampling survey in Ontario. So that's a method of chain referral sampling where people recruit other participants and we track that so we can produce statistics that take into account the probability of recruitment, right? So somebody who knows a lot of eligible people, they're more likely to get recruited than someone who doesn't because there are more potential recruitment paths that lead to them. So that's what that is. And we define trans very broadly, and we wanted this to be open to everybody, and you'll see we had a lot of participants who were not out, who had not socially transitioned, weren't living in their gender at all, but they knew themselves to be trans. And I just want to point out, if you look at clinical research, it's different than a clinical sample. So less than half of our people had seen a mental health care provider who deals with trans issues in the last year. So some things that made this project, I like to think awesome, but you can have critiques and we can talk about those too. A commitment to community ownership and accountability combined with rigorous methodology and combined with a commitment to putting our results out there and doing that in ways that can be used by community members, that can be used by healthcare providers, service providers, and by policymakers. So what can we do with this kind of research? Well, one of the first things we can do, because we're focusing really on trans people here, is we can develop trans-specific theory. So in the first phase of our project, we did these community soundings, and we used a grounded theory approach. And this will be probably my only first authored qualitative paper of my life as an epidemiologist. And it was really cool. So we used a grounded theory approach, and we said, what really explains these situations people were sharing about exclusion in healthcare situations and other institutional kind of situations. And Vivian Namaste had already been talking about erasure as it applies to trans communities, and we wanted to say, how does this function? And so we developed a model from that of how erasure functions in informational and institutional contexts. So in informational context, there wasn't information being produced about trans people in research. There was also the assumption, because erasure can be passive as well, the assumption that it didn't exist even where it might. So it wasn't incorporated into textbooks, into curricula, into trainings. This then reinforced institutional erasure, where there's a lack of policies, forms, documents, infrastructure to accommodate trans people, because why do you develop policies for people who don't exist? And then the absence of those policies feeds back, and there's not really a drive to gather information because it's not something that's considered part of the structure. And then this all impacts trans individuals and communities. And we situated that in the context of cisnormativity, which is just the assumption that all of those different dimensions of sex or gender that I showed you, that they're consistent within individuals, and furthermore that they're consistent over the life course, that they don't change. And so that makes trans people invisible because there's not a possibility. You meet someone, they look like a woman, obviously they were a girl, obviously they're going to grow old as an old woman, obviously they have a uterus, if they have children they gave birth to them. There are all these assumptions that come with a cisnormative approach. And in research, that can be problematic. So the way it's worked implicitly in research is this, though we don't often acknowledge this. People do surveys, are you male, female? Somebody checks female, and then we use it in our research in place of things that we could have actually measured. So we use it in our research as a substitute for people who have a cervix, if we're looking at unmet need for pap smears, or people who have estrogen levels in the female reference range. Or if we're doing sexual health research, we'll assume that somebody who checks female and has anal sex was the receptive and not the insertive partner. We'll assume that they're socialized as girls, that they may have been pregnant or maybe in the future. They're not going to be in our groups of people at risk of prostate cancer. We may make assumptions about their social roles as well. But we don't really give voice. So cisnormativity, part of it is it's the infrequently voiced assumption that these things all go together. And for people who are interested in a research measurement validity kind of perspective, you can see that that's problematic because we could measure all of those other things, right? But we're not. We've got one question and then we're making assumptions as to what it means. So another thing that came out of our qualitative research was really a big push for quantitative research. So I think of this person a lot, but there were a lot of different quotes that said, people really wanted us to. I think one was blow those bullshit numbers out of the water. People felt very strongly. But this person said, all this time that I've survived, I'm one of the walking dead because we're not counted. We're not represented anywhere. And that was just 10 years ago. So I like to think we've made some progress in 10 years. But the point still remains. The people who aren't counted, when those data are used in policy or in other settings, they're invisible, and so that erasure is just perpetuated. So countering erasure with data. I'm not going to get to talk about all the things we learned in TransPulse. So I just want to say that we put out a lot of data because there was a big information gap. So we've published 19 peer-reviewed papers so far, with another under review and 5 almost ready to go in, and I think that's it. And 2 book chapters, and a whole range of topics related to healthcare, related to Aboriginal gender diverse people, related to HIV, related to a whole pile of things. What we also did is we put out these 2 to 4 page e-bulletins in English and French because community people don't want to wait 2 years for your peer-reviewed publication. And so we took, because there's such an information gap, we took key small bits of information and put them out so people could use them right away. We also realized we had this amazing data resource that we created. So we made that available, so if government or community agencies had very specific information needs, they could request an analysis of data to support that specific need. So that was really cool. So Children's Aid Society said, hey, we want to know about impacts of parental support for gender, because we want to do programs with foster parents taking in trans youth and programs working with parents. So we gave them a report on impacts of strong parental support. Ministry of Health, when they relisted surgeries, said we want to know what's the unmet need. We said we'll give you what we can figure out. And so we did this for a lot of agencies, and that was really cool. So if you want to read all of those things, you can go to transpulseproject.ca. Okay, find everything there. Okay, so what does that undoing of erasure look like? So what can you do with this kind of research? I've just got a couple slides for each of these. The first one is describing trans communities. Because there are a lot of assumptions that people have about who trans people are as a group. And so one of the first things we did, in fact, most of this is from the very first e-bulletin we put out, was to look at the socio-demographics within Ontario's trans community. So we said half are trans-masculine, about half trans-feminine, which countered the earlier clinical work that said that more people were trans-feminine. About 1 in 5 had only non-binary identities. 1 in 5 born outside of Canada, 1 in 4 racialized, 1 in 14 Indigenous. Geographically distributed just like Ontario's population. So that first report said 68% of trans people didn't live in metropolitan Toronto. And that was amazing because everybody outside of Toronto ran with that, because I think there had been the assumption on the part of service providers that trans people all moved to Toronto, right? And so just concentrate services there and it'll be okay. 25% are parents, a bunch have post-secondary degrees, and yet the median income is still incredibly low. So I want to say that these didn't differ significantly from the base population, with 2 exceptions. Trans people are younger and trans people make significantly lower incomes. We were also able to look a bit at sex and gender diversity and kind of life course type of issues with that. So the pie on the left is the age at which people were aware that their gender did not match their body. And so if you combine the blue and the green, you'll see that about 80% of people knew that their gender didn't match their body by the age of 14, and in fact most of those were less than 10. But that said, it wasn't completely uncommon to recognize that at a later age. The right pie contains only about the 80% who were living in their gender. So 22% weren't living in their gender at all. And so of those 80%ish, you can see that only about 8% were living in their gender at that young age. Now, I think if we looked at this now, it's going to start increasing because we have more kids coming out younger. With the internet, they've been able to give a name to what they're experiencing earlier and connect with other people. And those same kids who, a couple decades ago, they would have gone 10 more years thinking they were the only one in the world like themselves, are now able to connect with other people. But still, the other thing that this says to me as a researcher is that there's a difference between gender identity and lived gender, in terms of, there can also be a very, very large gap, so people can know they're trans for a lot of years before they express that. And that's really important to researchers because that period of knowing you're trans and not expressing it could have health impacts. And also because when we're trying to identify trans people in a population, we're getting a different group of people depending on how we define that. Okay, so another thing we could do is identify trans-specific factors that impact health. This is going to be different than the population data sets because those are looking at factors that, we want to look at smoking across the whole population and seatbelt use and things like that. With trans community research, you can look at things like parental support specifically for gender identity and expression. And I'm sorry if this is harsh, just these are really huge effects. These are youth who are out to their parents, 16 to 24, and the green bars are youth who say their parents are strongly supportive of their gender identity and expression. The blue are people whose parents aren't. And so you can see that youth with supportive parents, they're all adequately housed. I know that Dr. Abramovich, when he comments later, he's going to talk a little bit about the situation with youth and be able to get into some of the more real world issues with these kind of situations. But you see here, kids with strong parental support, they did better in all of these aspects: life satisfaction, self-esteem, much less likely to have depressive symptoms consistent with major depressive disorder. And when we looked at pasture suicide risk, they were down at about the level that cisgender LGB kids are, and versus the extraordinarily high prevalence of suicide attempts in youth without parental support. So this is just a simple descriptive cross-tabulation, and this has had an amazing amount of impact, as you could guess, right? So we've had parents say this was the most important single thing in terms of supporting their kids. Parent advocacy groups use this in terms of, countering people who will say they're harming their children by supporting their gender. This has been used in policy work with regard to the ban on paying for reparative therapies for trans people in Ontario, for trans youth. And so it's had a huge impact just with a simple cross-tabulation. Likewise, we looked at a whole bunch of factors in terms of the relationship to pasture suicidality for our whole population group. And not surprisingly, having trans-specific experiences like transphobic assault are associated with a much higher risk of being suicidal. And so we're able to actually look at the impact of some of these factors. And I know it looks bleak, but the impact that this has had in terms of, if I put up like the policies that have changed that have been based in part on some of these data, it's kind of amazing because it's actually been able to push people to understand the severity of the situation and take action. So those are cross-tabulations. We could also use more of our epidemiological superpowers and do more complex analysis to try to identify trans-specific strategies for intervention. And so one of the things that I did is I didn't want to leave, especially with those really harsh kind of statistics on suicide, I didn't want to leave everybody feeling like the situation was hopeless. I wanted to turn this into something where we had some direction for action. So we did additional analyses to try to ask, first of all, which factors might be modifiable, what are potential interventions, and can we see what interventions might potentially have a strong impact. So then we can look at more complex models. Everything in gray here is being controlled for, because that's things that aren't going to change, at least in our group of people. And we were able to look at the impact or potential impacts of everything that's in the blue shape here in the middle. So potential interventions that relate to social inclusion, increased social inclusion, protection from transphobia, and access to medical and social transition. And I don't get to show you all of the results. This is actually goes a little bit beyond the paper. I took the results from the paper where we used average marginal risks to do model standardized risks for what we would expect to see in the population if we were able to change the levels of those factors. And so, for example, if we were able to reduce transphobia down to the 10th percentile of our scale, which is the level where people experience perhaps sporadic episodes, but not a lot of frequent or high-level transphobia. And if we applied that to the estimated 53,500 trans people in Ontario, you could see that we would expect to prevent over 2,000 suicide ideations in a year and over 2,000 attempts. So these aren't firm numbers, you can't add them up and combine them together, but it gives you an idea of what kind of impact we'd be looking at in terms of the number of prevented cases of suicide ideation and number of prevented attempts. And that's the idea of saving thousands of people each year from the misery of that is pretty amazing. So those are community-based studies. We're focusing on trans communities. We can ask about things like, trans-specific negative experiences in healthcare settings, or transphobia, or gender support, and all of these things. But Statistics Canada and other agencies, they're not going to include those kind of questions in their surveys that apply to a really small subgroup. So why would we want to include trans participants in these kind of broad surveys? First, I think it reflects a respect for equity with regard to participation and representation. These are important values to us. But also it allows for the identification of health inequalities. I would argue as well, it has the potential to improve data quality in a couple of ways. One, by avoiding misclassification of trans people who are already participating in research, and one by improving quality of data on cisgender participants as well, by more specifically defining which dimensions of sex or gender are being measured in different situations. Because of that, also has the potential to allow for more detailed causal analysis of the effects of different dimensions of sex and gender on long-term health. So remember this, So we're back to measurement validity issues. So in terms of how we can produce better data on people who are trans and people who are cisgender, if we're looking at this from a measurement validity point of view, we have to ask, is it really a good proxy measure for these other things? Because that's functionally what we're doing, is we're implicitly using this combined sex-gender measure as a proxy for the things that we're actually interested in research. And we have some reason to think that it's not. So this is from a study on pap smears by age group in Canada from the National Population Health Survey in the 90s. And just draw your attention, these are just different time frames. So look at the one on the left for past year pap smears. So the researchers had originally concluded, if you look at the kind of hashed bars in the front, that there was greater unmet need for pap smear for women of older age. And so thus we were not meeting our goal of appropriately providing screening care by age group. But when they redid the analysis and they took into account hysterectomy, then they got the bars in the back that showed a different picture, where you don't have this rapid increase in unmet need or decrease in appropriate pap smear use, because in fact, not all of those people needed to get a pap smear. So the assumption they were making at first is checkbox female equals has cervix equals needs pap smear. And this isn't because it was full of trans guys in their women group, right? This is because hysterectomy is one of the most commonly performed surgeries in Canada, and because you don't get a replacement. So, and a lot of hysterectomies involve removal of the cervix and don't necessarily need a pap smear. So I just wanted to give you an example of a situation where actually differentiating between different dimensions makes a difference in research that's not just within trans community. Okay, so what could we learn from trans inclusion in broad studies? So the blue bars here are from Trans Pulse, the green are from the Canadian Community Health Survey, same years as our data, 16 and older, Ontario, so almost 40,000 people, age standardized to the younger age distribution of trans community for comparability. So you can see here, if we look at social determinants of health, that we see some pretty clear evidence here of educational disruption. So it looks similar to the Ontario population, what would be expected for the age range for all the other groups except for post-secondary. Less likely to have a completed degree, more likely to have a partial degree. Unless you think it's because trans people are more likely to currently be students, that wasn't the case. So I think it's pretty solid evidence of disrupted post-secondary education. So if we actually, just to go back, if we actually had that in the CCHS, we'd be able to do those kind of analyses all the time. So these population surveys, they look at social determinants, they look at healthcare access. You can see here trans people assessed healthcare availability in the province, exactly similar to the population. But if you look at unmet healthcare need in the last year, about a third of trans people had an unmet healthcare need beyond what would be expected for the population. These surveys also look at health behaviors, like this is heavy episodic drinking from a paper we just published. Just look at the left-hand side, so we don't have to explain all the bars. The blue is trans community overall, and the red is the age-adjusted CCHS data. And if you're curious about the higher ones, the highest one are trans masculine spectrum guys, the olive green. So these are the kind of things that we could produce if we had a way to assess sex and gender in population surveys that allowed us to identify trans people. So how are we going to do that in a meaningful way? This involves accurately identifying trans participants, grouping trans and cis participants on relevant measures where needed. So if we're looking at prostate cancer, we'd want to group people at risk of prostate cancer, which are people with a prostate, right? Accurately categorizing into large groups for analysis. So Stats Canada and other agencies, they're going to be looking at large groups that they can look at inequalities and track it over time. So how can we do that? Ensuring measures are stable over time to monitor trends and making sure they work across language backgrounds and literacy levels. So this is a little different than with community-based research. So this, for example, these were the sex and gender questions from Trans Pulse. And if you're a community member, you're attached to trans communities, you might think, oh, I've changed that. Probably so would we, because it's been 7 years. And that really just shows how rapidly language is evolving with trans community. But this is what we came up with for our 2009 survey date with the contributions of, I think, at least 30 trans community members. And so we were able to ask this broad check all that apply list of different kinds of identities, have an other and a fill in the blank. And it wasn't, we didn't have the kind of problems you would have in a population survey because everybody was trans. So if somebody wrote human, as they did, as their identity, we didn't have to say, is this person trans or not? Because we knew they were trans because they were completing the survey. So the fact that their gender identity was human or just me or, whatever, it wasn't a problem in terms of identifying trans people. So you can ask the kind of things that aren't going to work in a population health setting. So in my work talking to people about this, so I found that researchers, this is a broad generalization of what researchers want, what community wants, so take it with a grain of salt. Researchers always seem to start from, so we're asking, are you male or female? What category should we add to our one question, right? So the bad news for anybody who's thinking that right now is there's no good way to do that. So we just had an international forum in Amsterdam this summer, led by the Williams Institute at UCLA, and everybody was in agreement there's no good way to do this with one question. Why? Well, because trans people are going to check man or male, female, because that's how some people identify. If you want to actually identify trans people, you can't do it that way. And if you're expecting that because somebody's trans, they're going to check other, it's literally othering, right? So, yeah. So, and whereas community people tend to come on the side of wanting something like a community survey, something that has an open, fill in the blank, let me just tell you how I identify, or give me this check all that apply list with every possible identity we can imagine, which is lovely and beautiful because people have so many different identities. But now think of it this way. So I think there's an ethical issue with this because Stats Campus, if they could do that, they can write algorithms to recode everybody into the 3 categories they're going to have or 4 categories they're going to have at the end. But you're telling people, tell us who you are, and then somebody who doesn't know you is going to put you in one of these categories anyway, and we're going to analyze you that way. And ethically, I have a bit of a problem with that. I think it's better to ask people where they would prefer to be categorized than to write algorithms and have data analysts doing that after the fact. So there's some issues with that too in terms of just the ways that identities change and needing to have that stability. So as part of our method study, we evaluated 2 survey item sets, recruited participants online. So we had 311 people who completed, if anybody here did it, thank you, the most boring surveys in existence. They were all demographics. So there was a demographic survey, and then 1 to 3 weeks later, a second survey. We were evaluating not just measures of sex, gender, but also race, ethnicity, and sexual orientation. So I'm just talking about sex, gender today. And so 1 to 3 weeks later, they got the other set of those different things. And then we selected a maximum diversity sample of 79 and invited them to do that second one, followed by a Skype or telephone interview. And those ranged from, I think it was 24 to 82 minutes. So the sets that we tested, this is a version of a 2-step question. It's from the Genius group in the US, the Gender Identity and US Surveys group, I believe. Follow up to the SMART group, the Sexual Minority Assessment Research Team. So I guess if you're beyond SMART, you become geniuses. So sometimes you hear people talk about that 2-step question. There isn't. There are so many different 2-step questions that ask questions in different ways. What they share is pairing 1 question on gender identity and 1 on sex assigned at birth, so that you can combine those to both identify trans people and to categorize them in different ways. This one is one that they thought was a promising question and recommended for further testing, so I took them up on it. What is your current gender identity? Male, female, trans man, trans female, trans woman, gender queer, gender nonconforming, or a different, please specify. And what sex were you assigned at birth, meaning on your original birth certificate. So if you think of my list of dimensions here, you can see that this gets at these ones, right? We have gender identity, we have sex assigned at birth. We can cross-combine those to get at who falls under that broad trans umbrella where those 2 are not in alignment. And because they have response options that say trans man, trans woman, gender queer, we could probably get at trans identity or something approximating that. So I'd also like to point out, because I meant to earlier, that everything on this is subject to change over time with the exception of chromosomal sex and sex assigned at birth. So measuring this is also something that may have to be measured over time because researchers often would just ask sex question, ask some demographics at baseline, and then not follow up. These are subject to change. So the second question is a set that I wrote for the Ontario Health Survey people after they launched their survey and then realized they should have had some way of identifying this. So I'm going to tell you what we found. So these cognitive interviews, and so we did a mixed methods analysis, went back and forth, with our interview data and our quantitative data. Just a couple of things to get out of the way. No issue with missings, really. Wasn't that people skipped it. And even though most of the people we interviewed were cisgender, this is the only slide I have on cisgender people, so now you're going to see the rest of it and think we just interviewed trans, non-binary people, but we didn't. Just nobody really had any issues. They were able to answer these questions very easily. And even like our almost 80-year-old straight white cis guy from out west, who talked about, I think we call him Mr. Plain Vanilla. that's how he calls himself. I talked about this kind of newfangled ways of talking about things where we say gender instead of sex and people say queer and things like that. It wasn't really his way of thinking. He still had no issue with these questions, so that was really good to see. So no red flags. So my prismatic people are transmasculine and transfeminine. So if we looked at that initial question that gave people the option of are you male, female, or something else, one of the first things, I told you single questions don't work, is that this was really cognitively difficult for the trans participants. People really tried to figure out what is it the researchers are asking, and you can see they reached really different conclusions. And so what this tells us, as other people have said before, is that this kind of question is not going to allow you to identify trans people. They're not just going to choose other and write something in. And furthermore, you can see here because both groups also, some people went with sex assigned at birth, or maybe they went different dimensions of sex and gender. So you can see that it's also not giving you anything else. It's not clearly telling you sex assigned at birth. It's not clearly telling you gender identity. It's, in terms of data collection, not useful, right? So, I told you that, not everybody identifies as trans. So this is just from a participant who said they really liked one of the options that said, people with a history of transitioning because it wasn't part of their identity. I'm a person with a history, like a medical history. So this person said, maybe in a medical emergency I would say I'm trans, but, in a survey now. So these two measures largely agreed when we coded for gender identity. So here, you can see the grayed in boxes are where they'd be concordant on gender identity, where people would be coded into the same group. And you can see that those are mostly the same, and the discordant boxes are all zeros or ones with one exception. There's 7 people here. And these people all were exactly the same in terms of how they indicated things. They were female at birth, present as female, say that they're not trans, check gender queer, gender nonconforming, and they're all sexual minorities. So they all, in separate questions on sexual orientation, they all said that they were queer, they were lesbian, or they were bisexual, or some kind of sexual minority identity. And so this is interesting because it tells us one of two things. It either tells us that the language around gender nonconforming might be overly broad and capture people who are cisgender queer women, or it tells us that people aren't in agreement over whether non-binary people are trans, and so they're non-binary, but they said I'm not trans, right? But they're all living as women. They all said that their lived gender was as women, so I would probably err more on the side of the former, but we're kind of picking through their interview data. So that's, I think, a warning in terms of gender nonconforming and how that language is used. We also found that this didn't really capture Indigenous gender identities. So this participant says, I chose gender fluid or gender queer only because that's representative of my identity. I do identify as two-spirited, but sometimes the more gender fluid and gender almost like having a balance, that some days are more masculine and some are more feminine, and it fluctuates. So this person said that being two-spirited is considered sometimes under the trans spectrum, but it's more of a spectrum in and of itself that's inclusive of sexuality and gender identity. And this is something that we've heard from Indigenous people around two-spirit identities. And when I say two-spirit, I mean, as a term that was developed to communicate to non-Indigenous people. It's not necessarily the identity people hold personally within their own language or their own culture. So this really raised the issue of how can we be inclusive in Indigenous gender identities and other cultural gender identities within these kind of questions. So we looked at these measures as well for if we group people into transmasculine and transfeminine, which some people will want to do in research for broad categories, is that a good proxy for other dimensions? And so you can see of transmasculine people that less than 40% were living as male. Transfeminine people as female was a little higher, more than 70%. But the central point here, without having to think through what all of these mean, is that even if we just group people by transmasculine and transfeminine spectrums, we say you're trans because your gender identity doesn't match what you were assigned at birth, and we're going to group you into these two groups. It's still a really bad proxy for all of these other things we might be interested in for health research, which is why we need to look at those. So we looked at other issues that came up, so I'm just going through a couple more and then I'll tell you what we kind of came to at the end. One question that came up, we were looking at self-reported measures, so somebody's doing a survey and they're completing it themselves. But sometimes, say the census, household surveys, we ask one person in a household to complete it for everybody. So we were asked by one of the people who read our paper, can you see whether anything you have would inform that situation? And so, well, we didn't ask people about it directly. We had discussions like this with people. I choose to identify my sex as female because my family is religious. It's easier for me to identify as female because otherwise it's problematic. And then we asked, so you told your family, do they know you're genderqueer? No. This person identified as trans. They identified as genderqueer, but they chose female when they had to choose on that because they're not out to their family. So this raises a question too in terms of proxy reporting, because if we think back to that slide where we showed that people often know that their gender doesn't match their body at a very young age, and then it's many years later before they're expressing that. So how are other people supposed to know whether someone in their household has a gender identity that might make them trans, right? They might be more likely to recognize if somebody has a lived gender, if they're expressing their gender in a way that would indicate they're trans. So at the end of this, we came up with recommendations for further testing, and then there's some options to add in here, so I'll explain it. So what we would recommend for, and this is what we are recommending to Statistics Canada for things like the Canadian Community Health Survey, are a set of 3 questions, probably with an open write-in. 3 questions: what sex were you assigned at birth, meaning on your original birth certificate? And then if we remove that from birth certificates, we'll have to change that as time goes on. With male and female, we allow for an undetermined, but that's almost always changed fairly rapidly. So, which best describes your current gender identity? That acknowledges that it's maybe not a perfect fit. Which best describes, and people can choose to put themselves into a category for analysis that best matches where they would want to be grouped. Male, female, indigenous, or other cultural identity, and something else. And then we've given examples. We've tried to keep all of that language in parentheses so that as language changes over time, that can be changed, and it's just the for example. And also because it might be different in different languages, in French or in other languages where it's used. So we tried to keep the stems of the questions all very simple, and then examples could be specific, right? And also, Two-Spirit isn't actually an indigenous gender identity, but again, it had the broadest recognition. So versus words that people use in their own language are often not recognized by others. And Inuit people, for example, Two-Spirit's a very First Nations kind of thing, but Inuit people will often recognize it even if they don't relate to it. So it has wide understandability. And then there's an option after that for an open gender item to fill in, but it's separate. So everybody puts themselves in a category and then they can describe their gender. And so if people want to use that, it gives people a place to do it. It also helps researchers understand how people are assigning themselves to these categories when you actually have the text in terms of how somebody would identify their own gender. And then for people who indicate that sex assigned at birth and current gender are different, then we can ask, what gender do you currently live as in your day-to-day life, with options of male, female, sometimes one, sometimes the other, or something else. And this should be translatable into any language because it's super simple. So we're looking for things, again, that we're going to be able to use 10 years from now in the context of an area where language is rapidly changing, and things that can be used in different languages. And then, so this gives us these dimensions. Sex assigned at birth, gender identity, lived gender. We can cross-stratify those to produce 2 different ways to identify trans people, by gender identity or by lived gender. There's an option for personal gender identity with the write-in, and then there's options to add in for specific studies, the hormonal or anatomical information. Obviously, you're not going to ask that in equity surveys or things where that doesn't matter, but for certain health conditions, that's going to be appropriate. Bonus outness amongst trans people, so you can look at who's living in their gender. So here's the rationale: avoids unnecessary options for sex assigned at birth. Some people put intersex, but that's usually not assigned. That should be asked as a separate question, because some intersex people have trans experience where they're assigned something and then it doesn't match how they identify, and some don't. It's a really diverse group. Recognizes the distinctiveness of indigenous genders and other cultural genders. Doesn't differentiate between identities as men or trans men. So people really didn't like that in the option where you had options of, for example, women and trans women. They said they felt like they were expected to choose trans women, like a lesser kind of woman. And nobody was using that for analysis. They said you could see who has a trans identity. Nobody's ever using that for analysis, so we got rid of that. Simple wording to allow for change over time. Can be reworded for interviewer administrative surveys. Self-categorized by participant on what best fits them. And open-ended items. So that solves the problem of coding people. So I said people can identify, like in our surveys, they'll write in human or just me, or they'll write gay, because depending on culturally too, that might be run in together with gender identity. but it's hard to interpret because you don't know what somebody means by it. Or, we've had people who are assigned male at birth right in trans male, and that can be an identity of somebody who I would probably put in the category of trans women, depending on where you are. And so it makes it all a lot easier. And so this is all kind of moving forward. For people who've been following the news, you know that the last census, the issue of inclusion of non-binary people was brought to the attention of Statistics Canada, and they've made a commitment to changing those measures for the 2021 census. They've also made a public commitment to changing the measures in all of the surveys, and so that's super exciting, and for me, a super exciting time to be putting out these results, because if you go back and you look at the list of people who've given input into the paper, it includes a bunch of people from StatsCan and those agencies, so they're already looking at it in terms of their work going forward, which is pretty exciting. Thank you.
My name is Alex Abramovich, and I'm a research scientist at the Institute for Mental Health Policy Research at the Center for Addiction and Mental Health. And I've been addressing the issue of LGBTQ2S youth homelessness for the past 10 years. My work has predominantly focused on investigating access to housing programs and mental health services for LGBTQ2S youth experiencing homelessness, and looking at the different ways that organizational policies can actually work to oppress and further marginalize queer and trans youth. As a community-based researcher, I work closely with the young people who are affected most by these issues, as well as key stakeholders and community agencies to create action and to push for positive social change. Over the next 10 to 15 minutes, I'm going to be speaking a little bit about how public health research and research more broadly is important to the lives of trans and gender diverse people. I'll be providing a couple of concrete examples from my own research that further exemplify some of the key issues that Dr. Bauer raised in her talk with regards to data collection and institutional erasure. But before I begin, I would also like to acknowledge that yesterday was Trans Day of Remembrance, and it was a difficult weekend for many of us as we remembered and honored the lives that have been lost due to transphobic violence and hatred. As a trans person and as a researcher, I feel very honored to be part of this dialogue today. And I'd like to extend a special thank you to the School of Public Health for hosting such an important event, especially during a difficult time for many of us in the trans community at U of T. So I'm just going to start off with a little bit of background information just to provide some context. So we've known for a long time that queer and trans youth are overrepresented in the homeless youth population, but underrepresented in shelters and housing programs. And this is mainly due to issues regarding safety and violence and discrimination that occur on multiple levels. We know that there are up to 65,000 young people experiencing homelessness across Canada, and there are at least 2,000 young people experiencing homelessness in Toronto on any given night. Approximately 25 to 40% of homeless youth identify as LGBTQ2S. One of the primary causes for young people leaving home or for being thrown out of the house is family conflict, and that's regardless of gender or sexual identity. Identity-based family conflict resulting from a young person coming out as queer or trans is a major contributing factor to youth homelessness. And the experience of homelessness is quite different for queer and trans youth versus heterosexual cisgender youth. Trans youth, especially trans women of color, are often the most underrepresented group of people in the shelter system and in housing programs, and the most discriminated against group of people, because not only are they dealing with transphobia, but also racism and oftentimes homophobia as well. It is such a diverse population, and youth are often oppressed on numerous levels. So I'm going to speak a little bit about the issue of measurement. It's difficult to know exactly how many queer and trans youth are experiencing homelessness, and this is for a variety of reasons. Although research on LGBTQ youth homelessness has certainly expanded in recent years, there still is minimal investigation and large-scale data collection remains limited. In Canada, we have extensive research on youth homelessness. However, numerous studies have missed out on important opportunities to collect data on gender and sexually diverse youth. And numerous studies have also grouped trans youth under the label of sexual minority, which makes it very difficult to differentiate between gender identity and sexual identity. And while gender identity and sexuality overlap, they are not the same. Municipal and provincial point-in-time counts and street needs assessments up until fairly recently didn't even ask any questions with regards to LGBTQ2S identity. However, today we're slowly starting to see these questions included. In 2013, the City of Toronto Street Needs Assessment included a question for the very first time about LGBTQ identity. And their results confirmed that 21% of youth in Toronto's shelter system identify as queer or trans. And although 21% is certainly high, we have to take into account that many youth choose to not come out as queer or trans, and this is due to issues regarding safety. And of course, countless youth didn't even have a chance to complete these surveys because they don't access services because they're part of the hidden homeless population. Another challenge is that there's still quite a bit of work to be done with regards to sensitivity to training and asking questions regarding LGBTQ identity in a sensitive manner, and also making sure that every single respondent is asked the same questions. So for example, making sure that every respondent is asked about gender identity, and not just the respondents who are perceived to be transgender or gender ambiguous. And this is an issue that tends to come up quite frequently in my work with shelter providers. So my research has looked at some of the ways that institutional policies and institutions such as the shelter system can actually further oppress LGBTQ people, and how they can work to erase queer and trans youth through institutional erasure. Back to a point that Greta made earlier, institutional rules and policies that don't consider or include queer and trans identities, particularly trans identities, play a major role in rendering them invisible and thereby erasing them. Erasure begins when a young person first enters a shelter and undergoes a formal intake process where they're asked a series of standard questions, and they're asked to complete a series of forms. The information that's collected during the formal intake process is really meant to provide the shelter provider and the City of Toronto with key demographical information regarding service users, which is supposed to help guide the delivery of services. The questions that are asked during intake also help staff determine if youth belong in the shelter. And if they do, then which floor of the shelter they'll be placed on, which is usually the male floor or the female floor, which is already an erasure. The floor that a person is placed on oftentimes has much more to do with the staff's perception of that young person's sex and less to do with how that individual actually identifies. When services don't allow people to self-identify on key forms and only provide the option for people to identify as male or female, any identity that does not fall into the gender binary is not included or documented, which of course makes it very easy for service providers to say that trans people don't access our services. A young person that I once interviewed spoke at length about how he attempted to come out as trans during the intake process at a shelter. This is what he said. The intake was so shitty in terms of trans stuff. There's just no room for trans or even LGBTQ stuff on their intake. I tried to incorporate it because they're like, do you need subway tokens to go to your appointments? And I'm like, yes I do. I'm going to a trans program on Monday and I'm going to this trans program on Tuesday. And they just kind of ignored that. So there's this expectation that every single young person is going to fit into the gender binary. And it's this expectation that makes the shelter system and housing programs and many healthcare facilities especially difficult places for trans and gender nonconforming individuals to navigate. And even though today there's certainly much more awareness of trans identities, still trans people face high rates of stigma and discrimination in all aspects of life, which is why trans people face such high rates of mental health difficulties, unemployment, and homelessness. The Trans Pulse study reported that 77% of trans people in Ontario had seriously considered suicide, and that 43% had attempted suicide. Suicidality varied greatly by medical transition status. So with those who were planning to medically transition, either through hormones or surgery, but who had not yet begun, being the most vulnerable. Trans youth were found to be at the greatest risk of suicidality. They also found that with strong parental support, the risk of suicide decreases by 93%. So we know that parental support is critical to the health and well-being of young trans people. Unfortunately, I've worked with so many young people whose lives have actually been threatened by their own parents after they came out, which is why reuniting young trans people with their parents is sometimes not an option. The social stigma, discrimination, often keeps trans people out of housing programs and out of healthcare services, or unable to come out at such services because they may not know if it will be safe to do so, especially if they don't see themselves reflected in the forms that they have to fill out or the questions that are asked during the intake procedure. Many of the young trans people that I've interviewed have mental health needs that are not being met because they don't have a family physician. And this is because many of them have had previous negative experiences where they felt uncomfortable and they felt judged by physicians and felt that their gender identity and their sexual identity were always pathologized. The Trans Pulse study also reported that 21% of trans people had avoided the emergency department when they needed it because of their trans identity. And for those who accessed the emergency department, they reported having negative experiences, including hurtful or insulting language, and staff that thought their gender marker was a mistake. They also reported having to educate the emergency care provider about being trans. And among those with a family physician, approximately 40% had experienced discriminatory behavior from a family doctor, at least once, including refusal of care, refusal to examine specific body parts, being ridiculed, and the use of demeaning language. This past June, The Lancet published a special issue on trans health for the first time, as an effort to further understand and really to provide a framework to improve the health and the well-being of trans people globally. So of course there's no one solution to these issues, but through my work I have also found that there are different ways that we can address these problems, and I'm going to focus on one specific response. And this involves shelters and youth-serving organizations moving towards a more standardized model of care, including similar forms and questions during intake that really truly capture the diverse range of identities. Over the years, I've worked with shelters and youth-serving organizations and municipal and provincial government on updating forms and procedures so that trans and gender diverse identities are actually included in intake procedures and key forms. Oftentimes, organizations believe that by adding the option other after male and female, that they are all of a sudden trans inclusive. But still, of course, as Greta said, that only others people, and it doesn't actually allow us to capture people's diverse identities. Ensuring that young people's identities are reflected in the programs that they access for support, and including questions that are asked during intake, helps them know exactly what they can expect when entering a service. It will also allow services and the city to start collecting data that includes trans and gender diverse people, leading to trans visibility and hopefully trans competent services. So I'd just like to end off actually with a quote from a young person who I just recently interviewed, a young trans person. This is what he said. "Try living in a world where it's hard enough to love yourself, but even harder to be accepted. Going into a place where you think that you can be safe, going into a place where you assume you can get help, but every door you try to open is locked or sealed shut. You're trying to walk back to where you started, but that door is also locked. You try very hard to break down that door, and once you get through, you realize that you cannot be you." Thank you.